All right. So, a very good evening to all of you. So, just give me a quick reply. Am I audible and visible to all of you? Yes. So, am I audible and visible to all of you? All right. So, let us start the today's session of the PYQ series part 2, right? The discussion of the previous year questions. So as your exam is coming nearby, so the very important part of your preparation now will be the previous year questions, right? And let me start this particular session with a positive note. That is very important at this moment of time, which is required for you is the self-confidence. And please remember, self-confidence is one of a superpower. Once you start to believe in yourself, definitely the magic starts happening. This you have to understand and believe by yourself. And I do understand that the stress levels at this point of time will be very high for you. But remember, your success will be determined by your own confidence and as well as the fortitude, right? So your self-confidence is very important at this moment of time. And what about this handling the stress? I'm very sorry. Right. And what about the handling this particular stress? See, you are studying like 19 subjects. Like what you have to understand is that it is not the load that breaks you down. It's the way you carry it is very important for you, right? So don't imagine, don't have a stress or load of 19 subjects. The way how you carry the 19 subjects is very important at this point of time, right? And stress is one of the inability to decide what exactly is important. When you are under severe stress, you will not be able to decide by yourself what exactly is important for you to read. So that is the reason why you set your mind in a piece and your goal should be high. With this positive note, let us start the today's session, right? That is the discussion of the previous year questions. Now, let me just quickly tell you what are the batch courses which are going on in an academy. An academy mainly for the FMGE students, it has come up with 5 months program, and this particular batch course have started on February 6th, and it is totally 5 months duration, out of which from February to April it will be theory discussion, and from April to June it is the discussion of image based questions and previous year questions. And this batch course, right, it is with a very minimal price of 17,213 rupees, and if you use my code, that is MED10, you will get an additional 10% discount on 17,000 rupees also. And the students who are appearing for the NEET PG, right, the batch course which have started in an academy is the final booster batch course, in which it has been divided into 3 modules, module 1, 2, 3, right? And this batch course, the cost is around 3,919, and if you use my code MED10, you will get 10% additional discount on the subscription. And the another important batch course is mainly for MBBS Prof 1 students. Okay, so having said this, let us start the discussion on the PYQs, that is previous year questions. So today I'll be discussing mainly 2 topics PYQs. One is nephrology and the other one is the HIV infections. Now let us start with the nephrology first, right? So if you see this question, that is, one second, right? A 45-year-old man presents with a 6 weeks history of bilateral ankle swelling. On examination, his pulse rate was 72 beats per minute. Blood pressure is 126 by 68 millimeters of mercury. JVP, it is not elevated, and auscultation of the heart and lungs was unremarkable. He had no stigma of chronic liver disease. Which of the following is the most appropriate initial investigation in this patient? Right. Abdominal ultrasound, D-dimer, echocardiogram, the urine analysis. So what do you think is the initial investigation that you will be doing in this patient? Any one of you, please? The initial investigation. Now, if you see the correct answer here, it is the urine analysis. Now, why is that urine analysis being the correct answer? Let me rule out the other options and come to the correct answer here. So, you take the patient, there is no evidence of heart failure, right? There is no evidence of the heart failure symptoms. That means what? Like JVP is not elevated. And if you take the auscultation of the lungs, it is unremarkable. That means there is no crepitations, there is no third heart sound. So there is no evidence of heart failure. So echocardiogram is not required in this patient. Okay, next. Then the next important point is there is no stigmata of the chronic liver disease. So doing an abdominal ultrasound is not required. The another important point is the D-dimer. Now, if you are suspecting deep vein thrombosis causing deep vein thrombosis causing ankle swelling, DVT usually it will cause unilateral ankle swelling. Bilateral ankle swelling is not seen in case of deep vein thrombosis. So that is the reason why even your D-dimer is also the incorrect statement, right? So like what are the causes for ankle swelling? The very important causes for ankle swelling, that includes the heart failure. The patient is not having any features suggestive of heart failure, so echocardiogram ruled out. Then cirrhosis of liver, there is no stigmata of the chronic liver disease, so abdominal ultrasound ruled out, right? And DVT does not cause bilateral ankle swelling, so D-dimer is being ruled out. Then what would be the other important cause for the bilateral ankle swelling? That is the renal failure, or the other important condition is the nephrotic syndrome, right? The other important condition will be nephrotic syndrome. So if you want to diagnose the nephrotic syndrome, you need to do the urine analysis, because in nephrotic syndrome you will observe that there is proteinuria, right? And along with proteinuria you will have the presence of the abnormal substances also within the urine. So the answer here is the urine analysis, right? It is not your abdominal ultrasound or D-dimer or echocardiogram. Okay, now we will move on to the next question. Yes, Govinda, namaste. Right, now if you see the next question, a 72-year-old man is found to have acute kidney injury. Urine microscopy reveals the presence of the red blood cell cast. What is the most likely etiology of his renal failure? Tubulointerstitial nephritis, ureteric stones, microscopic polyangiitis, scleroderma, renal crisis. Now, what do you think is the correct answer in this patient? Okay, some of you have answered A. Right, let me tell you, the correct answer here is the microscopic polyangiitis. Why the answer is microscopic polyangiitis? Let me explain to you. Now, the presence of the cast, right? The presence of the red blood cell cast tells you that the pathology is within the kidney, right? That the pathology is within the kidney itself. Okay. Now, you take the other options. The RBC cast indicates the presence of the pathology in the kidney, and that too the glomerulonephritis. Now, among the options which has been given to you, what is that particular condition which will cause the glomerulonephritis? That will be microscopic polyangiitis. And this microscopic polyangiitis, like what type of glomerulonephritis do you see? You will observe necrotizing right, you will observe the presence of necrotizing glomerulonephritis, and that is what you will observe in microscopic polyangiitis. Microscopic polyangiitis, it is nothing but it is a form of small vessel vasculitis where there is involvement of the kidney and as well as the pulmonary capillaries. These two organs are commonly affected in microscopic polyangiitis. And apart from the kidney and as well as the pulmonary capillaries, the other structures which are affected in microscopic polyangiitis is gastrointestinal tract, heart, and as well as the muscles. And what will be the presentation in microscopic polyangiitis? Because there is involvement of the glomerulus causing glomerulonephritis, the individual will have hematuria, the individual will have proteinuria, okay, and there you have the presence of the RBC cast. Then what about the other options? You take the tubulointerstitial nephritis or ureteric stones or scleroderma renal crisis. You don't have in these three options, that is A, B, and as well as D, there is no glomerulonephritis. When there is no glomerulonephritis, you don't have the cast within the urine. So the presence of the cast within the urine tells you that the individual has the presence of glomerulonephritis. And among the options which has been given to you, the one which will be causing glomerulonephritis will be microscopic polyangiitis. And what type of glomerulonephritis is that? Necrotizing glomerulonephritis. So that is the reason why the answer in this question is C. Now, after having discussed about the cast story, next you see this is another important PYQ in the nephrology. Which of the following is maintained in the circulation when transiting through the kidney and not freely filtered across the normal glomerular filtration barrier? So the question is like which among the following, right, which among the following does not cross the normal glomerular filtration barrier? The options are the free light chains, glucose, glutamine, immunoglobulin A. Right. So in this question, the answer is right. In this question, the answer is immunoglobulin A. Okay. Let me explain you all the options. You take the glucose. And what is this glutamine? Glutamine is an amino acid, right? So this glucose and as well as glutamine, these are the small molecules, right? These are the small molecules. These two can easily get filtered through the glomerulus, right? Whereas you take this free light chains. These free light chains, most of them, they are filtered from glomerulus to the tubule, and again they are absorbed by the tubules, right? Again they are absorbed by the tubules. Which one? The free light chains, but they are filtered. But whereas you take immunoglobulin A, all these immunoglobulins, if you observe the size of these immunoglobulins, they are of very large size. So this large size immunoglobulins, they don't cross the glomerular filtration barrier. But in which clinical conditions the immunoglobulins can filter the glomerular filtration barrier is, that is in patients with nephrotic syndrome. In patients with nephrotic syndrome, right, there is glomerulonephritis causing damage to the glomerular filtration barrier, and that is the reason why the immunoglobulins can cross the glomerular filtration barrier. And not only immunoglobulins, in patients with nephrotic syndrome there is also crossing of your albumin, and even the immunoglobulin, that is globulin, is also being filtered out. Then even the other proteins like thyroglobulin, ceruloplasmin, all these proteins are being filtered out in case of nephrotic syndrome. Why? Because of development of glomerulonephritis. Okay, but whereas in a normal condition, the immunoglobulin A, because of its larger size, it cannot cross the glomerular filtration barrier. So the answer in this question is D. Now, after having discussed about this question, let me take up the next question. Okay, a 69-year-old, right, a 69-year-old man is diagnosed with streptococcal endocarditis and commenced on benzyl penicillin and as well as gentamicin for this streptococcal endocarditis. His renal function is normal on admission, but 1 week later it has deteriorated right, where the estimated GFR is around 28 ml per 1.73 meter square. And urine analysis revealed protein 3 plus, blood 3 plus, and ultrasound abdomen. It showed the presence of the normal sized kidneys with no hydronephrosis. And the serum complement levels are also low. What is the most likely diagnosis? Acute interstitial nephritis, acute tubular necrosis, infection related glomerulonephritis, microscopic polyangiitis, pre-renal failure. So what do you think is the correct answer in this question? Okay, now any one of you? The correct answer in this question is the infection related glomerulonephritis, right? Very good, Minu. Now let me tell you all the other options. Now the patient has been started on antibiotics like gentamicin and as well as the penicillin group of antibiotics, that is benzyl penicillin. Now this gentamicin, it can cause acute tubular necrosis. Gentamicin, it can cause the acute tubular necrosis. And you take this benzyl penicillin or you take amoxicillin. This amoxicillin, it can cause the acute interstitial nephritis, right? And what about the other options? The pre-renal failure can occur secondary to sepsis because the patient is having streptococcal endocarditis, and this streptococcal endocarditis can cause sepsis, and this sepsis can cause the pre-renal failure. So acute tubular necrosis, acute interstitial nephritis, pre-renal failure these are the differential diagnosis in this patient. But what makes you the answer infection related glomerulonephritis is because the patient urine analysis is showing 3 plus blood and 3 plus protein on urine analysis, and this will point towards glomerulonephritis, and this will rule out acute tubular necrosis, will rule out interstitial nephritis, will rule out the pre-renal failure. Okay. Now, what about this microscopic polyangiitis? Microscopic polyangiitis is a possibility, but this is not associated with low complement level. Now, if you see this patient is having low complement level, whereas in case of microscopic polyangiitis, the complement levels, they appear normal. So that is the reason why your microscopic polyangiitis is ruled out. But otherwise, in microscopic polyangiitis, there can be development of glomerulonephritis causing 3 plus blood, 3 plus protein on urine analysis. But the serum complement being low will rule out microscopic polyangiitis. So that is the reason why the answer is the infection related glomerulonephritis. Okay, right. Now we will move on to the next important previous year question. Right. Now, a 32-year-old man is referred to the nephrology clinic for the investigation of persistent non-visible hematuria, initially detected at an insurance medical examination. He is otherwise well, no personal or family history of renal disease. Blood pressure is also normal, that is 126 by 68 millimeters of mercury. The preliminary investigations reveal the urine analysis, blood 3 plus, the protein is being negative, the creatinine 1.13, estimated GFR more than 60. What is the most likely diagnosis in this patient? Right. What do you think is the most likely diagnosis in this patient? Alport syndrome, bladder tumor, IgA nephropathy, membranous nephropathy, vesico-ureteric reflex. Okay, so the correct answer here in this question is very good. So it is the IgA nephropathy. It is IgA nephropathy. Right. Now, why it is IgA nephropathy? See, what will be the one of the common presentation of IgA nephropathy is the common presentation of IgA nephropathy will be asymptomatic non-visible hematuria. One of the common presentation of IgA nephropathy will be asymptomatic non-visible hematuria. Now, what about the other options? You take this Alport syndrome. Alport syndrome is a possibility. Although the absence of deafness, there is, in Alport syndrome you will have deafness, anterior lenticonus, and family history should be there. But here what does it tells you? There is no personal or family history. There is no deafness. There is no anterior lenticonus. So that is the reason why Alport syndrome is less likely. What about the bladder tumor? See, you take the age of the individual is around 32 years. Okay, so usually the bladder tumors, like, they are very common in age group more than 40 years. Otherwise, the bladder tumor can cause the presence of this blood 3 plus, but the age is not matching with the bladder tumor. So bladder tumor is ruled out. Then what about this membranous nephropathy? See, membranous nephropathy, it will present with nephrotic syndrome. What does that mean? That means that, right, that means that in case of membranous nephropathy, you will not have hematuria, right? Blood 3 plus is there, that you will not have in patients with the nephrotic syndrome. So that is the reason why your membranous nephropathy is being ruled out. Okay, next. Now what about this vesico-ureteric reflex? See, vesico-ureteric reflex would rarely cause isolated hematuria with no evidence of proteinuria or CKD. So it is a rare condition to cause an isolated hematuria. Now, this vesico-ureteric reflex can cause what? Can cause focal segmental glomerulosclerosis. And focal segmental glomerulosclerosis is what? It is a form of nephrotic syndrome. And in nephrotic syndrome, what should be there? There should be proteinuria. But what is given in the urine analysis? The protein is negative. So that will rule out your vesico-ureteric reflex causing isolated hematuria. Okay, so the correct answer here is the IgA nephropathy. So in IgA nephropathy, like, there can be non-visible hematuria. Right, next. Now we will move on to the next question. Okay, so this is a question which you have to answer carefully. Right, there is a very high chance that you can do mistake in this question. Okay, a 60-year-old man with long-standing stage 4 chronic kidney disease presents with vague abdominal pain. Vague bony pain. Blood test reveals estimated GFR of 17, calcium is 11.7, that means it is elevated, right? And the phosphate level, it is 5.64 milligrams per deciliter. What is the normal value of the phosphate? 2.5 to 4.5. That means even your phosphate levels are also elevated. Parathormone level is elevated. Alkaline phosphatase 470 units per liter. What is this picture consistent with? Excessive vitamin D consumption, milk alkali syndrome, primary, secondary, tertiary hyperparathyroidism. What do you consider this as? Okay, so we have a student by name Dr. Reformer. That is, the tertiary hyperparathyroidism is the correct statement. Right, whenever you are given a question of chronic renal failure with hyperparathyroidism, what do we think about? We think about secondary hyperparathyroidism, but here it is not secondary hyperparathyroidism, it is tertiary hyperparathyroidism. Okay, now the question is why the answer is tertiary hyperparathyroidism. Let me try to explain to you. So what exactly you mean by this word, like tertiary hyperparathyroidism? When does this occur? Tertiary hyperparathyroidism occurs when, right, tertiary hyperparathyroidism occurs when excess of parathormone is secreted by parathyroid glands, right? Excess of parathormone is secreted by parathyroid glands, usually after long-standing secondary hyperparathyroidism, right? After long-standing secondary hyperparathyroidism. Okay, that is what is your tertiary hyperparathyroidism. I'll repeat again. Tertiary hyperparathyroidism occurs when excess of parathormone is secreted by parathyroid glands, usually after long-standing secondary hyperparathyroidism. Now, how can we conclude that the patient is having tertiary and why not the secondary? Okay, now let us take up the option by option. You take this excess vitamin D consumption. Whenever there is excess vitamin D consumption, there should be increase in calcium levels. And whenever there is increase in calcium, what should happen to parathormone levels? That should be reduced. But what is given in our question? The parathormone levels, they are elevated. So your option A is ruled out. Okay. Then what about this milk alkali syndrome? What is milk alkali syndrome? It is a condition in which there is high level of calcium in the body. Right? It's a condition in which there is a high level of calcium in the body, and this high level of calcium will cause shift in the body's acid base balance towards metabolic alkalosis. Okay, so there is high level of the calcium in the body, and this high level of the calcium will shift acid base balance towards the metabolic alkalosis, and that is the reason why there is loss of kidney function in milk alkali syndrome. Now in milk alkali syndrome, there will be high serum calcium levels. And what will happen to your parathormone levels? There will be low parathormone levels. But what is given in our question? High parathormone levels. And not only that, in these patients with milk alkali syndrome, there will be also low phosphorus as well. Right, low phosphorus as well. But what is given in our question? The phosphate levels are elevated. So that is the reason why your milk alkali syndrome is being ruled out. Why? Because parathormone levels in milk alkali syndrome will be low, but in patients with in the question which has been given to us, parathormone levels are high, so milk alkali syndrome is ruled out. Then what about primary hyperparathyroidism? See, now if you take this primary hyperparathyroidism, in primary hyperparathyroidism, TK, parathormone levels are elevated, and accordingly calcium levels are elevated. But in primary hyperparathyroidism, what will happen to phosphate levels? The phosphate levels should be reduced in primary hyperparathyroidism. But in our patient, the phosphate levels are elevated, right? Yeah, so phosphate levels are 5.64. Normal value is 2.5 to 4.5. So this elevated serum phosphate will rule out your primary hyperparathyroidism. Then what about the secondary hyperparathyroidism? Now, in patients with chronic renal failure, they will have secondary hyperparathyroidism. And whenever there is secondary hyperparathyroidism, what is actually the gland doing in secondary hyperparathyroidism? In chronic renal failure, right, the phosphate levels, they are elevated, right, mega. The normal phosphate levels are 2.5 to 4.5 is the normal phosphate levels, and here the phosphate levels are 5.64. That means it is elevated. Okay, right. Now how will you rule out secondary hyperparathyroidism? In patients with chronic kidney disease, calcium is initially maintained in the normal range by elevated parathormone. Actually, what should happen to your calcium in case of chronic renal failure? That should be reduced. You understand? And whenever there is hypocalcemia, there will be secondary hyperparathyroidism. And this secondary hyperparathyroidism will make the calcium level to the normal value. Right? Secondary hyperparathyroidism will make the calcium level to the normal value. But if you take our question, the calcium level are elevated, which is unusual in case of chronic renal failure. But when can it happen? Remember, whenever there is autonomous parathormone production by parathyroid gland, secondary to long-standing secondary hyperparathyroidism, then which is called tertiary hyperparathyroidism. In tertiary hyperparathyroidism, calcium levels are elevated, phosphate levels are elevated, right? And even your parathormone levels are also elevated. Okay, so that is the reason why the answer is, yeah, the answer is tertiary hyperparathyroidism. So I hope you have understood this question, right? If you have any difficulty in understanding this question, please let me know. I will clear your doubt right away. So I tried to rule out all other options. Why not primary? Why not secondary? Why it is only tertiary? Why not milk alkali syndrome? Why not excessive vitamin D consumption? So all that I have clearly explained. So if you have any doubt in this question, please let me know. I'll try to solve your question. Right. So I hope you all have understood this question. Now, let me just move on to the next question. Right. A 62-year-old man with stage 3 chronic kidney disease is noted to have hemoglobin 79 gram per liter. That means 7.9 milligrams per deciliter. WBC count 8,900, which is normal value. Platelet count 1.46 lakhs, borderline normal. MCV 76 femtoliters. What is the most appropriate investigation? Bone marrow biopsy, serum erythropoietin level, serum folate levels, serum iron studies, ultrasound scan of the abdomen. Now, please tell me what is the correct answer in this question. Okay, now, yes, I do understand many of you are opting the serum erythropoietin level, but the answer is not serum erythropoietin level. Okay, so we have only one student answering the question correctly, that is Mullah Anisul. That is, the serum iron studies have to be done. Okay, why? Let me try to explain to you. Now, in patients with chronic renal failure, the type of anemia that you will have is normocytic normochromic anemia. Normocytic normochromic anemia. That means in patients with chronic renal failure, your MCV will be normal. But in our question, if you observe, that is, the MCV is being reduced. Okay, so now the anemia what the patient is having here is not because of the chronic renal failure. What are the conditions where the MCV can be reduced causing anemia? That is the iron deficiency anemia. So that is the reason why you need to do serum iron studies. One more point is that you take the chronic renal failure. We have 5 stages, 1, 2, 3, 4, 5. It is only in stage 4 CKD the hemoglobin value will become less than 10. Right? The hemoglobin value will become less than 10 in stage 4. But what is given to us that the patient is having stage 3 CKD. When the patient is having stage 3 CKD, you cannot have the hemoglobin of 7.9 due to renal failure. Here the anemia what the patient is having is because of the iron deficiency anemia. And how can you say that? The MCV is also reduced. How much is the normal MCV? The normal MCV is around 80 to 100 femtoliters. And if you don't know this point, you will go for the option of serum erythropoietin, which is an incorrect statement here. So the correct answer here is the serum iron studies. And you take the folate studies. What should happen to your MCV? The MCV will be increased in case of the serum folate deficiency. And why? So your serum folate ruled out. And what about the bone marrow biopsy? Now, whenever you are suspecting bone marrow suppression, there should be pancytopenia, right? There should be pancytopenia. But if you carefully observe our patient, the WBC levels are normal and platelets are borderline normal. It is just only decrease in your RBC. So that will rule out your bone marrow suppression. So bone marrow biopsy is also not required. And what about the ultrasound abdomen? See, your platelet count is normal, WBC count is also normal. So the presence of hypersplenism is less likely. So your ultrasound abdomen is also ruled out. Okay. So the correct answer here will be the serum iron studies. Very, very important question, and you need to be very careful in answering these type of questions. Okay. Now, which of the following is true regarding peritoneal dialysis? Fluid removal is achieved by increasing the concentration of sodium in the dialysate. Hyperkalemia is less common than for hemodialysis. It is associated with improved patient survival compared with hemodialysis. It is unsuitable for elderly patients. Peritonitis is usually caused by gut bacteria traversing the bowel wall. Yes, Megha, it is only in stage 4 you will have the hemoglobin level dropping to less than 10 milligrams per deciliter. Okay. Now, here the correct answer is hyperkalemia is less common then for the hemodialysis. Now, what about the other options and why the answer B is correct? Let me explain to you. Now, you take the fluid removal. Fluid removal is achieved by increasing the concentration of glucose, right? By increasing the concentration of the glucose in the dialysate. It is not the increasing the concentration of sodium. So, your option A is ruled out. Then, you take the third option. It is associated with improved survival compared with hemodialysis. Let me tell you, there is no evidence of a survival benefit when hemodialysis and peritoneal dialysis have been compared. Both are like equally efficacious. Okay, right. And it is unsuitable for elderly patients is wrong statement. Okay, so this peritoneal dialysis, it is the most appropriate modality for renal replacement for elderly patients who may not tolerate the fluid and electrolyte shifts associated with hemodialysis. Those elderly individuals who cannot tolerate the hemodialysis due to fluid and electrolyte shift, in them the peritoneal dialysis can be comfortably done. There is no problem. Now, coming to peritonitis. See, peritonitis is typically caused by skin contaminants. Okay, peritonitis is typically caused by skin contaminants translocating through the lumen or along the tract of the peritoneal catheter. Okay, so that's a very, very important point. So, peritonitis is usually caused by gut bacteria is a wrong statement. It's a wrong statement. It is through the skin contaminants. Please remember, that's a very, very important point. So, the correct answer here is hyperkalemia is less common for hemodialysis, right? I'm sorry, hyperkalemia is less common than for hemodialysis is the correct statement. Okay, right. Now we'll move on to the next question. Which of the following is typical of development of the preeclampsia? Low serum urate levels, maternal history of cigarette smoking, occurrence in the mother's first pregnancy, onset of hypertension in the second trimester, prolonged prothrombin time. Right, very good, Ashutosh Singh. That is, occurrence in mother's first pregnancy is the correct statement. Okay, now you take, what about the other options? Now, what will happen to serum urate levels in case of preeclampsia is the serum urate levels may be elevated, and that will help in the diagnosis of the preeclampsia, right? And what about the trimester? Preeclampsia typically presents in third trimester, right? Typically presents in third trimester, and onset of hypertension prior to the third trimester, it raises the possibility of pre-existing renal disease. Okay, so preeclampsia typically presents in third trimester. Then, so that is the reason why your option D is ruled out. Then you take maternal history of smoking. Maternal history of smoking may actually reduce the risk of preeclampsia. May actually reduce the risk of preeclampsia. Okay, it will not increase the risk of preeclampsia. Then what about this prolonged prothrombin time? See, prolonged prothrombin time suggests the development of disseminated intravascular coagulation. It does not tell you about the preeclampsia, right? And please remember, preeclampsia is more common in first pregnancies or first pregnancy with a new partner. So that's a correct statement. So occurrence in mother's first pregnancy is a correct statement regarding this preeclampsia. Okay, right. Then the next question, if you see, a 62-year-old man presents with sudden anuria on a background history of several weeks of not passing, right? Anuria with background history of several weeks of not passing much urine. He denies dysuria or hematuria but admits to have poor stream for many years. He is normotensive and otherwise looks well and has no systemic symptoms. What is the best initial diagnostic investigation? Right, very good, Dr. Reformer. So the correct answer here is the renal ultrasound scan. See, anuria in this setting is probably caused by bladder outflow obstruction. So 62-year-old, what he might have developed is benign prostatic hyperplasia, and this benign prostatic hyperplasia is the one which is causing this poor stream of poor stream for many years, and that is making the individual to develop sudden anuria. Actually, if you take CT scan of the kidneys, a CT scan would likely diagnose this BPH, but ultrasound is best, quick and cheapest test. That is the reason why the best initial will be the renal ultrasound. It is not the CT scan. Okay, right. Then what about the other options? Urine analysis for RBC cast. RBC cast could indicate a rapidly progressive glomerulonephritis. Although this is much less common in the history which has been given to you. So urine analysis for RBC cast, no use. Then blood for urea and electrolytes will not be helpful in the diagnosis, although they should obviously be performed, and a biopsy should not be needed if the case or if the cause is the obstruction, right? So the correct answer here will be the renal ultrasound. When you are suspecting obstruction, renal biopsy, there is no use. And what about this electrolytes and renal function will not help in the diagnosis of the obstruction. It will tell you that there is renal failure, but what is the cause of renal failure will not be said by your urea and as well as electrolytes. So this is also of no use. The correct statement here is the renal ultrasound. Okay, so these are some of the questions on nephrology. Next we will discuss some of the PYQs on HIV. Jahid Ansari, if ultrasound is not there, then go with the CT scan. If ultrasound is not there, then go with the CT scan. Okay, what do we want here? We want the cause for the renal failure. Whenever there is anuria, definitely it is telling you that the patient is having renal failure. And doing electrolytes and renal function tests will not help you in the diagnosis of the cause of renal failure. So CT scan would be the next best test if the ultrasound is not there in your option. Okay, right. Now moving to the questions on the HIV. What is HIV? Protease enzyme responsible for budding of HIV from the cell, cleavage of post-translational regulatory proteins, fusion of HIV with the host cell surface, integration of viral deoxyribonuclease into the host genome, reverse transcription of viral ribonucleic acid to DNA. Yes, what would be the correct statement? Right, very good, Ashutosh Singh. So the function of the protease enzyme is the cleavage of post-translational regulatory proteins. Okay, now you take the other options. Okay, you take this particular budding occurs after cleavage of proteins by the protease. Okay, for that protease is not required. When will the budding occur? Budding occurs after cleavage of proteins by the protease, and protease is required for the cleavage of post-translational regulatory proteins, right? And you take this fusion of HIV with the host cell surface. Fusion, it is mediated after binding to CD4 and the chemokine receptor. Okay, so the fusion is mediated by what? It is mediated by the chemokine receptor. No way the function of your protease. Then what about the integration? See, for the integration of viral deoxynucleic acid into the host genome, what is required is integrase is required. It is not the protease. So what is the function of the protease? The function of the protease is the cleavage of post-translational regulatory proteins. It is not required for budding, not required for fusion, not required for integration. And what about this reverse transcriptase? Reverse transcriptase is the one which will, right? So reverse transcriptase is the one which will mediate the reverse transcription. Okay, so the correct answer here is the cleavage of post-translational regulatory proteins. Now one more very practically asked question: what is the risk of acquiring HIV during a single act of unprotected vaginal sexual intercourse when the male partner is HIV infected and he is not on antiretroviral therapy and the female partner is HIV uninfected. 0.001 percentage, 0.01%, 0.1%, 1%, 10%. What do you think is the correct answer? Right. So the chance that the female partner can get affected is that it is 0.1%. It is 0.1%. And there are several factors which will increase the risk. Now, what are those several factors which will increase the risk? Number one, the presence of the genital ulcers in the opposite partner. Presence of cervical ectopy. Then male partner, uncircumcised male partner, that will increase the risk. Then menstruation. Right? So these are the factors which will increase the risk of the transmission. Right? But with a single act of unprotected vaginal sexual intercourse from the male partner being HIV infected, not on antiretroviral therapy, the chance that the female partner can develop HIV infection is 0.1%. Okay, so please remember that's a very important point. Next. So HIV is another important area where many questions have been asked in your previous exams. And these are all some of the questions. What is the most sensitive blood test for diagnosing HIV during primary infection? The options are HIV antibodies detected by ELISA, HIV antibodies detected by Western blot, P24 antigen detection, polymerase chain reaction to detect the HIV RNA, rapid point of care antibody test. Yeah, Ashutosh, for suppose if the patient is on antiretroviral therapy, that 0.1% will become 0.01%. Right, so those students who have answered D, none of you have answered D actually. The correct answer is the D. The most sensitive blood test for diagnosing HIV during primary infection is the polymerase chain reaction to detect the HIV RNA. That will be the first best test. Right, followed by this, what is this basically? It is nucleic acid amplification test. Okay, followed by this, the second most important test will be the P24 antigenemia, and followed by that, the third important will be the detection of the HIV antibodies. But this HIV antibodies, they are detectable 2 to 6 weeks later after acquiring the HIV infection. So the answer is D. Right, now the next question on the HIV itself again. A 35-year-old HIV positive man presents with diarrhea for 4 weeks accompanied by tenesmus. Blood and mucus is present in the stool. He is not on antiretroviral therapy. CD4 count is 17 cells per cubic millimeter. Which of the following is the most likely diagnosis? Cryptosporidiosis, cystoisosporiasis, cytomegalovirus colitis, giardiasis, microsporidiasis. So what do you think is the correct statement? Very good, Neetu Pandey. Right. So the correct answer is the cytomegalovirus colitis. Now why? Let me explain to you. See, the presence of blood and as well as the mucus, right? The presence of blood and mucus in the stool together with tenesmus, right? Together with tenesmus. These are suggestive of large bowel diarrhea. These are all the features suggestive of large bowel diarrhea. Now, among the options which has been given to you, which organism can cause large bowel diarrhea? That is colitis. That will be cytomegalovirus, right? Whereas you take all others like cryptosporidiosis, isosporidiasis, giardiasis and microsporidiosis, all of them will cause small bowel diarrhea and they don't have this particular feature of tenesmus. Okay, so that is the reason why the correct answer here will be the CMV colitis. And Jahid Ansari, what is tenesmus? Tenesmus means sensation of incomplete evacuation of bowel is called tenesmus. Okay, right. Now, yes, Jahid Ansari, did you understand that? Now, you see the next question on the same topic of HIV. Which one of the following non-acquired immunodeficiency syndrome cancers has been shown to have an increased incidence in HIV infected patients? Anal cancer, breast cancer, melanoma, ovarian cancer, prostate cancer. Very good, Neetu Pandey. That is the anal cancer. Remember, HIV increases the incidence of virus related cancers. You take the anal cancer. Anal cancer is linked with the human papilloma virus, right? The anal cancer is linked to the human papilloma virus. And you take the all other cancers, they are not caused by the viruses at all. Okay, and what the HIV does? HIV increases the incidence of virus related cancer. Your human papilloma virus is causing the anal cancer, and that incidence can be increased by associated HIV infection. Okay, so the correct answer here is the anal cancer. All right, now we'll move on to the next question. In HIV infected women with CD4 count, these are all the previously year asked questions on the topic of HIV. CD4 count of 36 cells per cubic millimeter, presents with symptomatic anemia. She is not on antiretroviral therapy. Like full blood count, if you observe, hemoglobin 26, normocytic normochromic anemia with low reticulocyte index. WBC and platelet count is normal. The bone marrow biopsy shows pure red cell aplasia. This point is very, very important for me. That is pure red cell aplasia. Which of the following viral infection is likely responsible for this? Right. So immediately when you get this particular word pure red cell aplasia, you should go with the parvovirus B19. Parvovirus B19. Okay, so this parvovirus B19 is the commonest infectious cause of red cell aplasia in HIV infection. And the other drug, the other antiretroviral drug that can cause the pure red cell aplasia is what? That will be your lamivudine. Okay, that will be lamivudine. Okay, so and you take the cytomegalovirus and some other viruses may cause pancytopenia. So all these, they will cause pancytopenia, but they will not cause the pure red cell aplasia. So that is the reason why the answer is being parvovirus B19. Okay, right. And you see the next question. Which of the following is a clinical indication for starting prophylactic cotrimoxazole in HIV infected adults in middle to high income setting? Enlarged parotid glands, fungal nail infection, generalized lymphadenopathy, herpes zoster infection, oral hairy leukoplakia. Right. So what do you think is the correct statement? I mean, the correct answer. Prophylactic cotrimoxazole, when to start? Right. Very good, Neetu Pandey. Neetu Pandey has answered it correctly. The answer is the oral hairy leukoplakia. So now this oral hairy leukoplakia, if you take, it comes under your WHO staging 3 for HIV. It comes under WHO staging 3 for HIV. Whereas generalized lymphadenopathy, it comes under stage 1. Whereas oral hairy leukoplakia, stage 3. The remaining all, they come under stage 2. The remaining all, they come under stage 2. Now, which set of patients of high income categories, they require cotrimoxazole prophylaxis is those patients who have stage 3 diseases. They should be started with cotrimoxazole. Okay, of high income setting. Whereas if you take the patients of low income setting, in patients with low income countries, cotrimoxazole is given to all patients irrespective of CD4 count, irrespective of the clinical stage. Whereas High income settings, you should give in stage 3 and stage 4. What will be your stage 3 manifestations of your WHO? Weight loss should be more than 10% of the body weight. Okay, and there should be a chronic diarrhea more than 1 month. Persistent fever of unknown cause for more than 1 month. Oral hairy leukoplakia. Persistent oral candidiasis. Pulmonary tuberculosis. Acute necrotizing ulcerative stomatitis. Severe bacterial infection, unexplained anemia, thrombocytopenia, neutropenia. These all come under your stage 3. For them, you need to give prophylactic cotrimoxazole, even though they are coming from the high income countries. So the answer here is the oral hairy leukoplakia, right? Now we will move on to the next question. Right. So this is one important question which has been asked recently. Which of the following statement is true about the diffuse inflammatory lymphocytosis syndrome? Options are: DILS is recognized complication of co-infection with HHV8, risk factor for parotid gland lymphoma associated with polymyositis, characterized by infiltration of parotids with B lymphocytes, usually associated with marked CD4 lymphocytosis. What do you think is the correct statement regarding diffuse inflammatory lymphocytosis syndrome? Okay, so first of all, let me tell you, this particular DILS, that is diffuse inflammatory lymphocytosis syndrome, it occurs in patients who are HIV positive with low CD4 count. And what about the HLA association? Those individuals with HLA DRB1, they are the one who are at high risk of development of DILS. And this particular diffuse infiltrative lymphocytosis syndrome, like the manifestations will be similar to Sjogren syndrome. What will be that manifestations similar to that of Sjogren syndrome? That is enlargement of the parotid gland, enlargement of submandibular swelling, submandibular glands, and there will be sicca symptoms. And this diffuse inflammatory lymphocytosis syndrome, it will improve by treatment with highly active antiretroviral therapy. And these patients, they have an association with number of autoimmune disorders, including polymyositis. Okay, DILS is associated with polymyositis. So the correct statement here is C, right? And many of you answered D, characterized by infiltration of parotids with B lymphocytes. No, characterized by infiltration of the parotids with CD4 plus T lymphocytes. Okay, not B lymphocytes. So that is the reason why your D is an incorrect statement, right? And manifestation similar to that of Sjogren syndrome with painless parotid and submandibular gland swelling. So that is what is your DILS. One last question and then we will wind up this session. Okay, right. This is a very common scenario which we come across in our routine practice. A nurse administers an intramuscular injection to an HIV infected woman who is not yet on antiretroviral therapy. After the injection, she pricks her finger on the needle. What is the approximate risk of acquiring HIV following this occupational exposure? 0.003%, 0.03%, 0.3%, 3%, 30%. Right? So unprotected sexual intercourse, in that case, like what did I tell you the percentage the female can develop who is not having HIV? That is 0.1%, 0.1%. But with the needle prick, the chance of transmission is 0.3%. The chance of transmission is 0.3%. Okay, so these two you have to remember: unprotected sexual intercourse, man HIV, female non-HIV, With first sexual intercourse, the chance of transmission is 0.1 percentage. With needle prick, the chance of transmission is 0.3 percentage. Okay, so this is, yes, very good, Anubhav. It is 30% in case of the hepatitis B, right? So this completes the PYQs or the previous year questions related to nephrology and as well as the HIV, right? And immediately I'll send you this PDF onto my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? Medicine Made Easy by Dr. Rajesh Gubba. And if you are not able to get this particular channel, you can text me. I will send you the link of my Telegram channel wherein you will get the PDF of this particular session. And subsequently, I'll be doing the imageathon and I'll also be doing some more PYQ series. And if you want any particular topic to be discussed in detail, you can text me on my Telegram channel, which I will definitely do that. Okay. So thank you very much. See you in the upcoming sessions.